Good afternoon, and welcome to HealthSystemCIO.com's All-Star Panel, Interoperability Approaches That Keep the Data Flowing, a webinar tweet chat combo from HealthSystemCIO.com sponsored by Spok. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the Editor-in-Chief of HealthSystemCIO.com, and I will be your moderator today. We are having a simultaneous tweet chat hosted by Kate Gamble, our Managing Editor and Director of Social Media. You can participate in a separate browser or on your phone by using the hashtag HSCIOchat, or you can view the tweet chat in the Media Viewer panel on the right-hand side of your screen. Today we're going to also use the Q&A panel, which you can use to submit your questions as they occur to you. We'll take those questions later in the program, but go ahead and send them in when you think of them. Also, we're going to throw out a poll today for our audience, and you will see the polling panel open automatically when we launch that poll. Just so you see our panel today, how we're going to spend our time, we have with us Liz Johnson, CIO of Acute Care Hospitals and Applied Clinical Informatics with Tenet Healthcare. We've also got Brian Patty, Dr. Brian Patty, VP and CMIO at Rush University Medical Center. And we have Dr. Andrew Mellin, Chief Medical Officer with Spok. So let's get started. Brian, can you give us an overview of your organization, please?
Sure. Rush University Medical Center is located in Chicago. We have two community hospitals, Rush Oak Park and Rush Copley, in the western suburbs of Chicago. And we also have about 30 specialty clinics operated both on campus and throughout Chicago.
Excellent. And we're going to stick with you for now, Brian. We have Liz and Andrew should be calling back in momentarily. So let's get our conversation started. Brian, please give me your thoughts on the definition of interoperability. Help lay the groundwork for us today.
Yeah, so I mean, it depends upon who you talk to. You know, if you look at the meaningful use definition, it's that the information makes it from point A to point B. But if you talk to clinicians, they really say, I need that information landing within my workflow when I'm with a patient. And so the gold standard, and that it's available for whatever decision support tools I have set up within my EMR, so that that information is impacting care. And so the gold standard is that information is making it into the clinician's workflow, and it's impacting the care of the patient in front of them.
Very good. Liz, you're back with us, correct?
I am back. Sorry,
awesome.
Guys. I completely dropped, yeah.
No worries. Liz, let's back up a little bit. Just tell us a little bit about your organization.
Sure. So I work as the CIO for the acute care hospitals at Tenet Healthcare, and we are a large multi-state healthcare provider both in the ambulatory, the surgical centers, and the acute care hospital. And I would say, you know, obviously very large, 130 to 150,000 people working for us daily, just delivering care in the best way we know how. And I'll let it go at that, considering I know I took a few minutes to get back in. Great organization to be involved with.
Oh, fantastic. I don't know if you caught Brian's definition of interoperability, but we'd love to hear your thoughts.
Of course. I did not, and I did hear the very end of it, and so I would be completely in agreement with it. I would say it's secure information available where and when it's needed. I think it's a very lofty definition and aspiration, but I really think it's where we want to go, and certainly so it's available to our clinicians, because the goal is to improve patient care. I mean, really think about it. If we can improve the quality and efficiency across the continuum, you know, it's the right information at the right time. It's just not a very easy thing to do. So, and again, I heard the end of his and absolute agreement, it really has to be put into clinician workflow or it's not useful.
Very good, very good. Andrew, you with us?
Yep, I'm here.
Oh, excellent. Can you give us a little bit about Spok? Tell us about your organization.
Sure. Spok is a company that provides healthcare communication and collaboration solutions. We are at over 1,900 hospitals across the world, and we help organizations with everything ranging from secure messaging for the care team to the contact centers to interoperability solutions for patient care devices and pagers. So really a wide gamut of healthcare communication solutions for organizations.
Very good. And your thoughts on the definition of interoperability?
Sure. When I think of interoperability, I kind of break it down into three parts. The first part is sending information from one system to the other, so kind of the sort of technical parts of being able to get information out and receiving it. The second part is the semantic interoperability, so making sure that the meaning of the information coming from the first system is understandable by the second system and interpreted in the exact same way. And the third part, which is really the most important part, is that information is able to be translated by the receiving system into some form of value, some form of value for the end user, whether it's a patient, a provider, a nurse, wherever. That information is only useful if it can be used to advance patient care or help make decisions. So it's really the three parts that I think about with interoperability.
Very good. Thanks for helping set the stage on that. Liz, let's go with you on this one first. What do you see as the fundamental barriers to achieving interoperability, really, while we're on the call today?
I would say, it's a great question. I think while we try not to get stuck on it, we can't ignore it, right? So I think, first of all, we don't have agreed upon standards. I think there's always this kind of sense that there is a lack of standards. That's really not the issue. The issue is that we don't have an agreement on a single standard. There are plenty of standards out there. Another thing I think about a lot is our patient identifier. We don't yet, and I think we're going to talk about this a little more later in the call, but we have algorithms to match patients. We have biometrics, and we'll get into that. But we do not have a national patient identifier, and that's always going to create an issue for us. And then finally, I think we have this fear or this concern about information blocking. We think that there's an expectation, obviously, that we won't block information, and I don't think any of us, at least certainly not to my knowledge, do it intentionally. But what is the actual, what do we mean that when we say information blocking? Is it the expectation that every single piece of data is available all the time? Is that realistic? Is it based on permissions? What does that mean, and how do we get through that in terms of creating a world where data flows freely and securely, but is not, is a reasonable expectation? And I think the final one I would say is security. I think we are really, really worried about, with all the cyber attacks and all the things that are going on, can we provide data across a number from outside organizations into our internal organizations safely, protecting not only the patient's privacy, but making sure that once that data is either in transit or inside of an organization, can we keep it secure and not be attacked and have that data become available in an inappropriate way? So the challenges are many. I think we still continue to always circle back to we want to get there, so we're not going to let these barriers stand in our way, but they're very real.
Very good. Andrew, your thoughts?
Yes, so great points from my colleague. And, I will recognize, though, that we have made tremendous progress to date. I mean, while we talk about fundamental barriers to achieving interoperability, we are doing across this country a lot of interoperability over the past decade. So it's exciting to see the progress. I think to continue to see advances, in addition to what we just talked about, I would also add that health systems and the buyers of these solutions can really help drive the vendors to put interoperability at the top of their list to make the change. There's nothing like market pressures to force and drive the various communities of vendors to really work together and help the health systems achieve their goals. So, I would say as much as a barrier per se, well, it's partially a barrier in that, as a vendors, we have lots of priorities. We have a lot of requests, a lot of things that our customers want to do. And as we have, continued to hear more and more a desire for continued interoperability, that drives our priorities to align with our customers. So, again, progress to be made. Some fundamental problems that still need to be solved that are being solved. But again, continuing to have the market pressures and whether it's from the health systems or the patients push the vendors, I think will continue to help advance this.
Excellent. Brian, your thoughts on the barriers?
Yeah, I agree with both Andrew and Liz. I always say the good thing about standards in healthcare is we have so many to choose from. But it's true, and that can be a good thing and it can be a bad thing. When I look at what our options are for interoperability, we have a lot of arrows in our quiver, if you will. At Rush, we don't look at interoperability as a single way of moving data. We have multiple strategies, and we try to apply the best strategy to the best solution. And so, majority of our patient care data flows through, Epic's Care Everywhere. But we also have a private HIE for our clinically integrated network partners who are not on Epic. We're starting to use Care Equality for those members that are in the Care Equality network, and then obviously we're using some direct messaging, some point-to-point interfaces, and most recently we've started to use the FHIR protocol to exchange data between some of our partners. Also agree with Liz, unified patient identifier, we just need to get there. We're working with complex algorithms to try and match patients. If we had a unique patient identifier, we would be much better off, and my sense is that would make our interoperability tasks much easier. But we have to deal with the environment that we live in right now.
That's the truth. All right, before we move on, we're going to have a little audience poll, which you should see opening up right now. Can the healthcare industry solve its interoperability problems without major help from government? Can we do it on our own, or does government have to step in and really lay down the specifications of standards and things like that? So we will discuss that in a moment. Please go ahead and answer that, and we will keep our conversation going and visit the results in a minute. Brian, let me start with you on the next question. And you see you've got a lot you can go with here. Which efforts offer the most promise for furthering interoperability? You've got initiatives such as the Argonaut Project, Sequoia Project, Jason Report. You've got networks such as Commonwealth, Care Everywhere, and SureScripts. You can bring in the NPI discussion, and you can also discuss 21st Century Cures Act. So lots to touch on there, Brian.
So like I said, the main solution that we use, since we're an Epic shop, is Epic's Care Everywhere. We really see a lot of utility to that. It proactively brings patient data into our provider workflows, and then they can accept that data into our instance of Epic. We're starting to see a lot of traction with Care Equality as well. And similarly, Epic has configured that for us so that that data flows in and is viewable by the provider. They wouldn't necessarily have to know that patient has data elsewhere. It just shows up in a summary screen for the provider, and they're able to then view that data, and if they want, reconcile that data into our EHR. And so we're really leveraging those two very, very heavily. And then, as I mentioned, we do have a private HIE for those instances where we have partners who aren't able to utilize those first two solutions, or where we need some administrative data to manage some of our contracts and things like that.
Very good. Andrew, you want to jump in wherever you like there on this question?
Sure. You know, it's exciting to see all these initiatives over the past few years have really addressed some fundamental challenges of interoperability and moving core patient data. And I think the 21st Century Cures Act will, again, continue this momentum and pressure across the industry to drive this. I also do want to recognize, though, that there's been a lot of work done by organizations like IHE, which if you're not familiar with it, it's IHE, which stands for Integrating the Healthcare Enterprise. What they've done is taken a lot of the standards that exist and created these cross multidisciplinary collaborations with vendors and with customers and device manufacturers, and have solved a lot of the hard problems that exist when you're trying to do interoperability. You know, a good example of this is while these initiatives here are all focused on the EHR, there's been an explosion of patient care devices and biotechnology that support and measure patients in the hospital, and the data that those systems generate is really important. You know, in the moment that you're working with a critically ill patient, they're connected to 5, 10 different devices, all emitting information that you want to use for alerting, you want to get into your EHR, and without interoperability, without that way to communicate the data, without the semantic understanding, and without the ways to add value to that data, everything would live in isolation. So these are all very promising, but I do want to recognize that there are organizations that have been around a while that are continuing to make tremendous progress on interoperability. And, you know, we as a healthcare country, both on the provider and vendor side, need to continue to support those efforts too.
Excellent. Liz?
Sure.
Liz, if you want to specifically talk to the networks and the NPI issues.
Sure, I'd be glad to. Well, first I want to give one kind of call out for Commonwealth as well. I mean, I know that, like Brian, we have Epic Hospitals, but we also have Cerner and Meditech and McKesson and Allscripts. And I think what we're really looking for is interoperability that uses, you know, a multi-vendor, multi-stakeholder coming together so that the data can move freely across, and I think that we are making great efforts in those ways. And I think, you know, care quality is one of those things that will help as long as we also include Commonwealth, who's now joined that whole effort. I really think on the NPI, I think, you know, Brian said earlier, we have very complex algorithms, and we can use those effectively to match patients, but the reality of it is often the most, you know, the quick match that comes up almost in a default kind of a way is where the registrar or scheduler or whomever who's matching, not really identifying, but matching the patient stops. And so we end up with some really you know, kind of scary times in terms of maybe the patient wasn't actually the match correctly. Then we have, you know, biometrics, and we think about that, which is much obviously better at matching if we have something to match it to. So there's kind of two issues there. One is, while an iris scan or a thumbprint or something of that nature is obviously much more accurate than using an algorithm, it requires expensive equipment, and again, you have to have something to match that iris to make it actually work. So I think, you know, we've got some challenges there. We know that the federal government has recently come up with a Medicare beneficiary identifier in replacing of the Social Security number, and again, it's limited to a very specific population, and I'm not sure it will completely solve the problem, but it's a step in the right way, in the right direction, but not all the way there. And then finally, I think we have to talk about the federal government is still prohibited to fund these kind of solutions. The law says they cannot do that. So I think we are very dependent currently on our private industry, which is not a bad thing because I think we're very innovative and can come up with solutions, but we're not there yet. I think, you know, from a 21 Cures perspective, I agree with everybody that this is a real opportunity to spur us on. We need to figure out who wants it. We'll talk about that, but you know, the rules in 21 Cures, the ideas, the concepts behind it are solid, and it's really talking about having the data when we need it to provide the right care to the right patient. all concepts we believe in. The how is not yet determined, and we're slowly getting off our feet in Washington and beginning to give us the guidelines for how that might work. It's a perfect opportunity for us to step in and really provide information in providing that how do you get there, how do you do that, what would make the most sense. So I think, if you think about it, identifying patients, matching patients, we've got to get them then figured out in the simplest of terms, and then we actually have to come back and match it to the data that goes along with it, not just in a single institution. I mean, that's for me, one of the biggest challenges we have. I think Andrew talked about it, but it's not just the information I have in my four walls or on my campus with multi-kinds of care delivery systems, but it's the campus down the street that's not using the same vendors that I'm using or not using the same tools. How does it all come together, and who's going to drive it?
Very good. Go ahead.
Along those lines, I noticed a question from Justin Campbell on the Q&A line about EPIC and what initiatives are spurring interoperability outside of EPIC. I really see, there's all this talk about information blocking, and I just don't think that the concept exists. I've found EPIC to be a great partner in helping us exchange data with healthcare systems and clinics that are not on EPIC, whether it's care equality or care elsewhere or other solutions. They've been a good partner for us in enabling data exchange. I'm also excited to see how the patient-enabled interoperability market's going to expand. I'm sure a lot of people that are listening saw EPIC's announcement of Share Everywhere, where patients can basically allow a provider who maybe doesn't even have an EHR, but just has internet access to their information through the new Share Everywhere concept, and I think patient-enabled interoperability, I think, will become more and more a driver in the interoperability market.
Very good. Excellent. All right, we're going to take a look at our poll results. You should be able to see those now. So, can the healthcare industry solve its interoperability problems without major help from government? The response was 36% said yes, 64% said no. Liz, as a policy person, what do you think of those results? What you expect, or are they out of line?
No, I think it's exactly what I expect. I think that we often find that if the federal government drives it through regulation or policy, and whether it's an incentive like MU was or eventually a penalty, same with macro and MIPS, and we can go on down the line, it is faster, we get it faster because we can use that as a lever to get it funded and to get the attention put on it. I think it's a shame because I think that we know that the innovation that exists in the private industry is potentially much greater than what we'd find in the federal government, and the federal government can either be very restrictive around what they expect, and I hate to see that. I think what our pollies are telling us, though, is absolutely true, is that what we've seen year in and year out, that we've got to have a driver. And if it's not going to be private industry and it's not going to be the patient, then it's got to be federal government.
Andrew, your thoughts on the poll?
Yeah, I agree. I guess maybe I'm a little more optimistic that I hope private industry and collaboration with the health systems that are very engaged in this will drive continued improvements. And certainly we're seeing things through Commonwealth and care equality and other and some of the work out of FHIR that is somewhat tied to the work done by the government, but have taken a lot of initiative on others. So I certainly think the government certainly spurs the growth of it or the attention, but I really hope and I'm optimistic that with the momentum that we have, we continue to make these improvements without having to have a stick from the government every time we want to take a leap.
Yeah, and I think I've seen, the private industry coming together. There's been a great initiative from CLAS over the last 3 years with their interoperability cornerstone summits. And bringing both vendors and providers and other engaged parties, including elements of government, all to the table and really talking about how can we together solve this interoperability problem. That's a problem for all of us. And, I've seen, vendors and providers working very well together in the room, identifying the issues and coming up with solutions. And if you look at the last 2 years where CLAS has measured interoperability, what they call deep interoperability, where it's actually impacting patient care, we've really moved the dial there. A year ago, providers who were polled really said only about 6% of the time is data from outside of my organization, from another EMR vendor, impacting care at my institution. And that number's moved up to 14% in this, I hope CLAS doesn't mind me kind of spilling the beans a little bit, but on their interoperability report that's going to come up out in a few weeks, we've seen that number rise to 14% of that deep interoperability, which is data from a different EMR vendors making it into my EMR and having an impact on patient care. So we are seeing industry really coming together and solving the problem. We have a long way to go, but we're seeing some significant movement.
Very good, very good. All right, Liz, let's start with you on this one. How are hospitals balancing the need for one source of truth with all the different systems they're using? How do you make decisions around when to choose technology that is interoperable versus single platform? Do you buy a niche system that has limited interoperability or a platform that is integrated? How can hospitals leverage the investment made in their EHRs to interoperate with other systems and enhance their workflows?
And I suppose you want me to say more than just very carefully, right?
Yeah, maybe a little bit more. Just a little bit.
I thought you might.
Although that sums it up.
Yeah.
I think what we're doing is, it is clear to us that the pendulum has clearly swung back and forth across the continuum. Years ago, we really went with best of breed, and there were really good reasons for it. Those persons who invested heavily in a single vertical, whether it was a laboratory or a CPOE solution, and I can go on through the list, were very, very robust solutions. But the problem was we couldn't get them to talk to each other except with interfaces, which was very self-limiting. So we then swung the pendulum more toward the other end, which was let's buy a single integrated platform and ask it to do everything. And that has been successful. It certainly, as a result of the MU movement through high tech, we've seen integrated solutions across the United States in a way we've never seen it before, not in all care delivery environments, but in most. The challenge becomes that very large vendors often have difficulty being quickly robust and getting things through their systems in a way that a web developer or someone who has a cloud-based solution can provide us with really fast, really robust, really customer-centric, meaning our clinician, our patient, and so on. So what we've chosen to do is to come up with kind of a hybrid where we are looking at what I call bolt-ons, for the lack of a more fancy term, where we can provide immediate functionality and a very quick turnaround time, well-tested and secure, and we can expand the use of all of the various vendors that are available across the United States quickly. We still worry about integration. We have looked for the kinds of things we've been talking about throughout this call to be able to bring all that data together, because regardless of how you get the functionality started, if the data gets entered from another place and it's not integrated into the data available to provide care, we haven't accomplished what we need to. I think there is always going to be a problem with money and how much money can you spend to do all these things. I think we have to really look at our markets and our communities, and are what we're doing working? Because what works in Birmingham, Alabama versus what works in Modesto, California are different. The expectations of the markets are different, and we need to be aware. And if there's a solution that's been selected with other partners in our geographical areas, we should be looking at that as an opportunity because it will make a difference. The idea is that not to think in a singular way or a vertical way, but instead to think horizontally across your care continuum and how can we best deliver care with data that is available when it's needed.
Excellent. Andrew?
Sure. I think back to the days when the CPOE systems and the pharmacy systems were separate, and organizations spent a huge amount of effort trying to make them work together. And, I think the health systems and the market quickly learned that some parts of patient care and health IT just truly needs to be one system. Another quick story I heard actually this morning was about communications, and one health system was trying to roll out an enterprise-wide communication platform that had a good way to communicate, but there was a surgeon who happened to come from another health system that had that platform, it wasn't ours, and really didn't like it. And so he went and did his rogue thing, got approval for an own OR communication schedule. No one knew about it. It got installed and put in the ORs. Well, it failed because they could communicate among themselves in the OR, but they couldn't communicate with everybody else in like post-op and the floors and everyone else that they need to talk to. And so I think about it the same way in that there are parts that need to be tightly integrated because the sort of fluidity of the data and the deep integration, you just can't achieve through interoperability. But there's plenty of other areas and opportunities where you can supplant the core or enhance the core systems with other kinds of solutions. And I view the EHRs as these great, amazing tools that emit a whole bunch of signals that come out that often don't go anywhere. But an example we think about is when that EHR detects someone has sepsis, it doesn't do any good if that alert fires in isolation or fires in the background. So how do you take that information that's being generated by the EHR, how do you take through interoperability and deliver it in this situation to a rapid response team and the physician and nurse who need to jump in and act on the patient. So I think you are going to have these core systems that are very tightly integrated. EHR, your probably communication platform, maybe your analytics platform and some other things, but then an ecosystem of other targeted systems that solve key problems that the other systems don't solve.
Very good. Brian?
Yeah, I agree with what's already been said. I mean, I think most organizations have realized, let me limit the amount of internal interoperability that I need to do by moving as much as possible to a single platform and getting away from the best of breed solutions. But you still end up even internally having to communicate with, devices, other applications, as Liz calls them, and I agree, kind of bolt-ons that fill in the gap where your EHR vendor doesn't have a solution, and you still have to connect to those. We're starting to see a lot of good use cases for FHIR in those instances where internally we're looking at how do I get the data out of this application and into Epic and vice versa, or how do I make it look like that application is actually a part of Epic using FHIR protocols in Smart on FHIR to really enhance the workflow of our providers and make it so that they can sit in a single workflow and don't have to go to other places to get data.
Very good, very good. All right, let's go to our next question. Andrew, this one's for you, really. From the vendor perspective, why do you think it's important to be able to speak with multiple systems And can you talk about any interesting or unique use cases of people integrating your solution with other systems to improve workflow?
Sure. I'm going to start with the second one first. This one is really interesting at a large academic medical center. They are always trying to find people to enroll in their research studies, but they also struggle with sort of finding and getting in contact with people when they're on campus. And so one of the interesting interoperability things that they did is they are taking the data that their EHR generates, harvesting it, using some standards, and looking for signals that when someone walks into a clinic or comes on campus for something that could be eligible for research, they immediately send a message, a notification to the research coordinator for that project, who can then go meet that person while they're physically on campus and get them enrolled in studies. We're also seeing a number of interesting interoperability with various patient care devices where as these devices emit different kinds of signals, instead of simply sending off a light where a nurse would have to respond to every kind of alarm that's possibly going off, let's say for a telemetry alarm, we can look into the data that's being generated by those alarms and route them, and organizations can say, okay, if it's just a battery, we're going to send it to a tech. If it's VFib, we're going to send it to a whole bunch of people really quickly. And so I think taking sort of those standards and applying intelligence on top of that to deal with things like alert fatigue and deal with other kinds of organizational challenges to make sure the information is acted on by the right person. And you can only do that with interoperability, making sure that both the sending and receiving systems are speaking the same language and can understand each other. So in summary, I mean, why is this important? Well, if the EHR just lived in isolation, if systems just lived in isolation, we would all be essentially beholden to a single vendor and their priorities and their abilities to advance your care. And I think, as some of my colleagues talked about, you wouldn't be able to look for innovative ideas elsewhere. So when health systems are putting out RFPs, when they're looking to evaluate vendors, I think it's critical for them to make sure that they are putting in the standards organizations that exist, and then the standards that exist. So the partner they end up going with will be able to interoperate and won't, be viewing their information as proprietary and locked in. So it's critical.
Excellent. Okay, let's go with Brian on this next question. What responsibility, if any, do patients have in the quest for interoperability?
Well, a number. Obviously, there's in some states, in order to exchange data, you have to, the patient has to opt in. So in that instance, the patient obviously has a huge responsibility, or at least role in the interoperability milieu. But my sense is I think we're going to see, as I mentioned earlier, with Epic's announcement last week of Share Everywhere, I think we're going to see a lot of patient-controlled interoperability platforms where the patient is able to extend a token to a provider to enable them to pull patient data from one location to another, and also to be able to send data back to that location. And so that you're going to see some movement of data based on patient-enabled tokens and patient-generated interoperability.
Very good. All right, we're going to.
Anthony, let me
ahead.
take a look. Sure. I think what we, beyond just our partners in the technology world, I think we really need to talk about the fact that patients have to really want it. What we've seen consistently is chronically ill patients pay attention. People that are taking care of dependents, whether they're elderly or children, want their information exchanged. But overall, in a big grand scheme way, it's still not there yet. So I think crisis helps. You know, you see Harvey and Irma, you see that we actually had data available. It wasn't necessarily in the right place, but at least it didn't get destroyed this time like it did at Katrina. So that's a tremendous step forward. But I think we really have to continue to look at, and I know that Brian and I were recently in another setting, and we're talking about the fact that there has to be a driver, there has to be a want for this, and I don't think we've found that magic key yet. And so I think as we find that, not by either asking ourselves, not as CIOs, but as people, as patients, as you know, those who need that care, why would we want it? And if we play to the need, then the desire for it will significantly increase.
Very good. All right, we're going to look at a few audience questions now. First question, let's go with you, Liz. Is Tenet using Commonwealth? I don't know if that's the correct phrasing. Is Commonwealth something you okay,
yes.
Go ahead.
Yes, we are participating in it. Well, the way we started with it was Resonance, which is really just a tool that, again, I try to stay away from the specific tools of our vendors. Resonance is a Cerner tool. We also use the Epic tools, but we are using Commonwealth to a certain extent to do it as an overlay. We think that as Commonwealth has joined Care Equality, what we're really looking for is the big overarching organization that's, you know, not-for-profit, that is really working toward getting a way of exchanging data. And I've said it as simply as kind of the same reason we use Direct, is that we're really looking for a way to exchange data with all partners, regardless of their EMR vendor, in a very effective way.
All right, very good. Brian, let's start with you on this. How are you handling sensitive data and pediatrics in your consents for admission process? You
know, we have the sharing of data built into our universal consent, and we walk through that. We have certain areas of data that are called out. You know, obviously, genetics is a big concern for a lot of patients. Sensitive results like HIV status and things like that. And any notes that are associated with a psychiatric visit. And so we typically call those out specifically, that the patient has to specifically say that those are okay to share when we get a request to share data. And the same thing goes with pediatric data. So, you know, specific cases where we say that it doesn't fall under our universal patient consent. Patients have to specifically consent to share certain types of data.
Liz, can you offer anything around that, handling sensitive data?
Yeah, I think Brian did a great job. I think the reality of it is you have to be aware of your state and federal laws, particularly state, are going to be potentially more rigid. You have to be aware, particularly in the area of the minor child, whether they're emancipated or not, and the rules are very, very specific, as they are with certain health conditions. So I think you have to have policies and procedures that cover you, but check the word procedures, meaning turning into a process. So stating that it should be done in a manner and not having a way to meet that obligation is not effective. So you need to translate policies into a process and use technology any way you can to make it happen. It is a hard road, and you have to stay on top of what the, you know, kind of evolving or rules are, because again, the rules continue to change and become more complicated. I think we're all about, we probably lean toward being more protective than less, because it's one of those things where as much as I don't want to ever fail to provide any data that's appropriate, I do want to protect the rights of the patient.
Very good, very good. Let me pose this to you, Andrew. Do you have any tips on how hospital leaders can partner with vendors to achieve their interoperability goals?
Yeah, I think there's a couple things. One is, you know, first of all, in the selection process, many of the organizations will even give you language to include in your RFPs and RFIs to make sure that the vendors are compatible. I think number two, working with your vendors to help create real-world business and clinical use cases that add real value. You know, I think it's extremely helpful when we have organizations like I've worked with Brian in the past, you know, this partnership between the vendor and the provider organization to make sure what's being created works well in the real world and has real value. And the third thing is, and the sort of a broader answer, is that I'd strongly encourage organizations to get involved with the very standards organizations. You know, what you don't want is these standards organizations to have, you know, academics and only vendors trying to think about how to solve problems, and you come out with something that's unwieldy. I think some of the most successful partnerships are when you have this really large multidisciplinary collaboration that brings together the various stakeholders and try to come up with an optimum solution that works in the real world. So I would just, again, put a plug in to get involved if this is an interest for you.
All right, very good. Next question from the audience. We hear most commonly, and this is from class, our friend Bob at class, we hear most commonly that one of the largest issues with use of exchanged information is that there is simply too much data. Where are we seeing progress in getting the right and just enough information to clinicians? Let's go with you, Liz.
Yeah, great question. The answer is that we're not there yet. I mean, obviously we use exchange of data standards, and we talk about allergies and problems and medications and all those kinds of things, but I think the reality of it is when you get into specialty, which everyone has a specialty, you know, what a cardiologist is interested in a cardiac unit is interested in is very different than what a maternal child physician would require a pediatrician. And so I think we are a long way from that. I think we know the basics. We know you've got to know what meds I'm on, what my history is, you know, what my allergies are. But when you get into really customizing according to the disease condition that's being treated, we've got a long way to go. I wish I had a perfect answer, but I don't.
Brian?
I absolutely agree with what Liz just said. I mean, we can turn on the fire hose and let people drink because there is, you know, if we get really good at exchanging data, there's a lot of data out there that can be exchanged. And so it's really, again, you know, as Andrew mentioned, you know, as a provider, working well with your vendor partners. And looking at ways of what's the presentation layer look like, and so as as the data is flowing in on a patient, how do we then cull that data? How do we validate that data, and then how do we present it in a way that's consumable by the end user? Because, as you know, most primary care physicians have 15 to 20 minutes per patient, and they don't have time to weed through a ton of data on a patient. We have to, as informaticists working with our vendor partners, we have to work at ways of displaying the data in the fashion that the provider needs it displayed, and that will, and as Liz mentioned, that will vary by specialty and by provider, and so it's going to be very, very challenging as we start receiving more and more data. How do we validate that data? How do we move that data into our EHR in a way that's usable by our providers?
All right, I'm going to give everybody a chance before we go for a sort of call to action of what you want your colleagues and folks to do to help push things along. So Liz, let me start with you.
Well, I would say first and foremost, make sure interoperability is at the top of your agenda. I know it is, but make sure don't get overwhelmed by the barriers and the complexities. Start small and grow to bigger. Make sure that you're staying informed with what is going on as far as the initiatives, whether they be federal or state, whether they're in the private world around advocating for patient identifiers and tools that increase interoperability, recognizing that often the connectivity initiatives that we do, they overlap. So you have to think about that. And then finally, learn how to tell your story in a simple way. It is very difficult as CIOs and other healthcare informatics leaders. We often end up kind of falling back to the acronyms we understand, the technology we understand. But if we can tell a story that's about how a patient didn't get the care they needed because the data wasn't available or because we couldn't properly identify, that story is far more powerful and much more likely to help us move our cause forward.
Very good. Brian?
Yeah, I always say that interoperability is a team sport. And no single group or sector is going to solve it. And so we as providers have to work well with our vendor partners and with the government and with our patients to really solve interoperability. And we have to continue to look at it as a team sport, and we all have to really all play well together in the sandbox and keep the patient at the center of this, understanding that our ultimate outcome is really improving patient care. And that's what it's all about, and that's what we're all in this game for. And if we really do a good job of exchanging data and making sure that the patient data follows them wherever they go, we're going to see markedly improved outcomes in this country.
Andrew, last word goes to you.
Sure. Great advice from my colleagues, and I would just like to add, get involved. Most of the standards are made by volunteer organizations and facilitated by, great organizations. And just like anything, the provider organization's voice representing the patients and the needs of the providers is often the most powerful. And so I would encourage, whether it's you or others in your organization, to find the areas of interoperability that you think need improvement and need help. Find the organizations that are supporting it and get involved. Be part of governance bodies, be part of standards bodies creating these things, be a voice of the real world, and help drive these things forward. I mean, again, it's exciting to see the progress we've made. We have a long ways to go, but yeah, it's a great path we're on.
Excellent. Well, I think it was a wonderful event. When you close out your WebEx window, you're going to be taken to a survey. If you could take a moment to answer that, we'd appreciate it. For those of you with continuing education interest in today's program, attending our webinars gets you one CEU towards the CHIME CHIO certification program. So let CHIME know you were here, and if you've asked us to do so, we certainly will. You'll receive an email when our archive recording of today's event has been posted to our YouTube channel. If you'd like us to produce a webinar on the topic of your choice, you can contact Nancy Wilcox from our team. You can go to our website to see our upcoming schedule. So with that, I want to again thank our panel, Liz Johnson, Brian, Patty, and Andrew Mellin. I want to thank Spok for sponsoring today's event and making this important conversation possible, and I want to thank you, our attendees. Everybody have a wonderful day. Thank you.